Wellbeing Series webinar. I'm Dr. Mary Jo Kreitzer, the founder and director of the center. For more than 25 years, we've been advancing health and well-being within people, organizations, and communities. We are very excited to be hosting as our speaker today, Dr. Julianne Holt-Lunstad, who will be speaking on the clinical and public health importance of social well-being. At the Botkin Center for Spirituality and Healing, we recognize that relationships are core to well-being. Relationships are one of the 6 dimensions of our well-being model, along with health, purpose, community, security, and the environment. For many years, you may have heard our experts share that isolation is fatal and that building relationships and creating community connections can help prevent loneliness. This week, as the trial of Derek Chauvin concluded in Minneapolis, the social fabric of our community and the importance of relationships has been in the spotlight as we've had to face systemic racism as a reality in our community and as a nation. A headline in the paper this morning captured the sentiment of many, a sigh of relief and a glimmer of hope. Lots of work ahead so that we may heal individually and collectively. It's my honor to introduce the speaker today. In the format for today's webinar, Dr. Holt-Lunstad will speak for about an hour, and after that, we will open it up for Q&A. And please note the Q&A button at the bottom of your screen, and you're welcome to start adding questions at any time during the webinar. Dr. Julianne Holt-Lunstad is a professor of psychology and neuroscience at Brigham Young University, an adjunct professor at Swinburne University of Technology in Melbourne, Australia, and the founding chair of the Scientific Advisory Committee for the Coalition to End Social Isolation and Loneliness. Her research is focused on understanding the long-term health effects, the biological mechanisms, and effective strategies that can mitigate risk and promote protection associated with social connection. Her work has been seminal in the recognition of social isolation and loneliness as risk factors for early mortality. Dr. Holt-Lunstad has worked with government organizations aimed at addressing social isolation and loneliness as risk factors for early mortality. She's provided expert testimony in a U.S. congressional hearing, provided expert recommendations for the U.S. Surgeon General Emotional Wellbeing in America initiative, and is currently a member of the technical working group for the UK cross-departmental loneliness team. Additionally, Professor Holt-Lunstad runs the Social Connections and Health Research Laboratory at Brigham Young University. So welcome, Dr. Julianne Holt-Lunstad.
Thank you so much for the warm welcome. I am just thrilled to be here. This is such an honor to be able to speak to this group. And while I'm grateful to be with you all virtually, I sure wish I could be there with you in person. I'm actually a Minnesota native. I was born and raised in Minnesota. So hopefully one day I will have the pleasure of meeting you all in person. I'm going to go ahead and share my screen. I'd like to share some slides with you. So I'll go ahead and take a minute to do that. So today I'm going to be talking about an issue of social connection and disconnection, what the significance is of this issue, its health impacts, and some potential next steps. And before I begin, I wanted to just give you a little bit of background and of course some disclosures. And as noted in my introduction, I'm a professor of psychology and neuroscience at Brigham Young University. I also serve on a number of unpaid scientific advisory boards, and I consult with, for instance, a design firm that helps companies draw upon scientific evidence to inform their products or services. Um, and I was also a member of the National Academy of Science Consensus Committee that recently issued a report on the medical and healthcare implications of social isolation and loneliness among older adults. And I'll be drawing upon this report in my remarks. But I do want to note that this report is available to the general public. So to get us started, and I want to engage you all, I wish I could see all of your faces, but I'm assuming you're all smiling right now, I hope. But I want you to take a minute, and I want you to pull out your cell phone. Now, I'm not going to ask you to turn it off. In fact, what I want you to do is go to where you store your photos. And I want you to scroll through and find a recent picture that captures happiness and joy. So take a minute, get that open. I want you to scroll and find one. Find one that literally makes you smile when you look at it. Now, chances are, and if you want, you in the chat feature, you're welcome to, note what it is that your picture captures. But chances are this photo is of a moment that you shared with someone else. Either literally you were together in that moment, or you captured this moment to share with someone else. Now, this really shouldn't be very surprising because across multiple studies, when subjects are asked, what brings you happiness? It isn't money or success. It's satisfying relationships with family, friends, and other close relationships. It's our relationships. So it's not surprising that most of us recognize that our relationships bring us joy or influence our emotional well-being. However, when it comes to our health, it's assumed to primarily be an issue of mental health. Unfortunately, few recognize the profound effects that our social connections can have on our physical well-being. And I'm going to talk a little bit more about that. Now, it's been a little over a year now since the World Health Organization declared a pandemic, and the term social distancing became a part of our collective lexicon. Now, of course, I've taken exception to this term. I wish it was, physical distancing or something along that line. But, with this, there has been growing concern. What will these social distancing and other restrictions do to us? What is known about the short-term and long-term effects of social isolation and loneliness? Who's most at risk? How might this influence public health and society long-term? What can we do to stay socially connected? Now, unfortunately, I don't have definitive answers, but drawing on previous research and some preliminary research that has been coming out recently, we can begin to address some of these questions. Now, of course, social isolation or concerns about the effects of social isolation aren't new. There was already substantial evidence of public health concerns even before the pandemic. So just 2 weeks before the World Health Organization declared a pandemic, the National Academy of Science Consensus Committee published a report that concluded that social isolation is a major public health concern. Of course, this report took about 18 months to complete. So we had no idea to what extent this issue would become top of mind for the nation and of course for the world. Drawing upon this report And the past decade or two of my own research, as well as the larger body of scientific evidence, we can begin to tackle some of these very pressing questions. So in this talk, I will summarize this evidence, but I'll also point out gaps in the evidence and how the pandemic has posed unique challenges. And finally, I'll highlight some important implications for public health. I want to first clarify and distinguish between some related but distinct concepts. So I wanted to distinguish between being homebound, social isolation, and loneliness. So homebound is rarely or never leaving the home over the past month. Social isolation is objectively being alone or having few social relationships or infrequent social contact. And loneliness is the subjective feeling alone. It's the discrepancy between one's desired level of connection and one's actual level of connection. So, of course, these can co-occur, but not necessarily. For instance, I'm sure every one of you can think of a time where you were alone, but you didn't feel lonely. You might have taken great pleasure in that alone time. And conversely, times where you were surrounded by other people. So you weren't isolated, but yet maybe you felt profoundly lonely. So these can co-occur, but don't always. Another related term that I want to include here is social connection. And that is an umbrella term that encompasses the structure, functions, and quality of social relationships, all of which may contribute to health and well-being. And I'll come back to this concept later. So how many people want to know, how big of an issue was this before the pandemic? And is there evidence that the pandemic is indeed making it worse? So many people, asked even prior to the pandemic, is there a loneliness epidemic? Of course, it's hard to, determine whether epidemic is even a term that is appropriate. But in terms of trying to determine whether prevalence rates are increasing, exact prevalence rates are actually quite difficult to determine, given that there's no national or international assessment or classification standard. While there are several surveys that are well validated, not all studies or surveys use the same measurement tool. And even among those that do, they may use different cutoffs to classify people as lonely. But even prior to the pandemic, there was evidence that a significant portion of the population was socially isolated, lonely, or both. While several national surveys have documented these prevalence rates, according to a 2018 AARP study, 1 in 3 older adults is profoundly, and other surveys suggest that it may be higher. For example, Cigna's national survey reported the prevalence rates at 46% in 2018, and then 61% in 2019, suggesting loneliness was on the rise even before the pandemic. And while there are several indicators of social isolation, one that's routinely collected in the US Census is living alone, which has been shown to steadily increase over time and may be relevant in light of the pandemic and among at-risk populations. Several surveys suggest that loneliness occurs across age, gender, income levels, and living situations. So no one seems to be immune to loneliness. However, the rates do appear to be highest among younger samples, those with lower incomes and those with chronic health conditions, as well as those living alone. Now, what about during the pandemic and all the necessary stay-at-home and social distancing recommendations? Of course, researchers have been trying to determine if it's been increasing, and if so, among which groups. And of course, this has also had its challenges. Given that many of the surveys are cross-sectionals, or cross-sectional, meaning that participants are asked about their perceptions of how their loneliness has changed. Whereas others are comparing data collected prior to the pandemic to data collected during the pandemic. Now, among those cross-sectional surveys, it suggests that between 20 to 40% of adult surveys report that they are feeling lonelier now than they did pre-COVID. Among those that have multiple time points, we actually have mixed evidence. For example, a study out of Florida State found minimal changes across the early months in response to COVID-19, suggesting perhaps either some degree of resilience or simple stability. However, data from the National Poll on Healthy Aging suggests changes in both loneliness and social contacts, such that there was an increase in the percentage of older adults that lacked companionship, felt isolated from others, and had infrequent social contact. Now, of course, additional research is still coming in, and so we're still learning more about this. But the most vulnerable and at-risk populations may be most severely affected, and unfortunately are also often the hardest to reach, and therefore underrepresented in research. And so we need to keep that in mind. The increase in distress due to limiting social contact that many of us have experienced over the past year, and perhaps are even continuing to experience, is a normal response. Humans are social beings. We aren't meant to be alone. Now, I snapped a picture of this water bottle that one of my research assistants brought into one of my lab meetings. I love this because it's so closely tied to the work that we've been doing. But this idea that humans need other humans really seems to carry much more meaning now. Several neuroscientists, including the late John Cacioppo, have argued that loneliness is our biology, signaling a need to reconnect socially. Just like hunger and thirst signal us to eat or to drink water, loneliness is thought to be a biological drive that motivates us to reconnect. So have we, or do we literally crave human contact? Well, a recent study out of MIT found that 10 hours of social isolation had a similar neurosignature as 10 hours without food, suggesting that acute isolation causes social cravings similar to hunger. So it seems to be consistent with that notion. This is also consistent with other evidence that humans need other humans. Humans are one of the most vulnerable species at birth. And of course, throughout human history, we have needed others for our utter survival. Indeed, early research found that infants and children in custodial care that lacked human contact failed to thrive and often die. But we have evidence from a variety of disciplines that demonstrate the importance of social ties across the lifespan. So this isn't just limited to infancy. And in fact, given this historical need, some some scientists have argued that our brains have adapted to expect social proximity. And some neuroscience supports this notion of social connection as being adaptive. So, for example, work by Jim Cohn suggests that we use more metabolic resources when we are coping with a threat when we are alone than when in the presence of others, particularly trusted others, suggesting that biological manifestation of motivational cues to maintain close social ties. Other research also suggests that social pain and physical pain may carry similar neural pathways. This is noteworthy because social isolation is thought to be distressing, and it's so distressing that it has been used as a form of punishment and even torture. And yet, for the past year, much of the world's population has had to drastically reduce our social contact. So many have wondered, as we face a novel and deadly virus, of course, it was clear that slowing the spread of this virus was paramount. But should we be concerned about social isolation? Or is this much more secondary? Uh, it's important to note that social isolation and loneliness are more than just distressing feelings and can have potentially deadly effects. Now, these deadly effects of social isolation and loneliness are not limited to suicide and domestic violence, both of which have been shown to increase. But we have robust evidence of the increase of risk of death from all causes. Now, this conclusion comes from decades of epidemiological research. In my own research, I sought to determine the overall magnitude of effect of various forms of being socially disconnected by examining the available epidemiological data worldwide. And after a thorough search of the relevant databases, my colleagues and I conducted a meta-analysis which included 70 prospective studies. This included data from over 3.4 million participants, followed for an average of 7 years. And after accounting for multiple covariates, analyses revealed that loneliness is associated with increased risk of earlier death by 26%, social isolation by 29%, and living alone by 32%. Conversely, in an earlier meta-analysis of 148 studies examining the protective effects of being socially connected, we found that social connection increases odds of survival by 50%. So, what exactly does this mean? And what exactly is social connection? I touched on it earlier, but let's go into this a little bit more in detail. So this data was based on all of the available data worldwide that had measured some aspect of an individual's relationships and then followed them over time to determine who lived and who died. And so this, was on average 7.5 years, but some were followed for decades. And so that 50% is based on an average across any measure that captured some aspect of one's relationships. So again, I want you to take a moment and I want you to think about what you think would be the most important thing to measure about your social relationships, about your social connections. And feel free to put this in the chat. And, is that, the size of your social network? Is it how frequently you interact with them? How meaningful those relationships are. And unfortunately, I can't see your responses right now, but what I suspect is that there's a huge variety of responses. And this table that I present here, don't worry about all the details. But my colleagues and I created this table to illustrate the wide variety of ways in which our relationships have been measured. So these are the measurement approaches that have been used in the scientific literature, but also the variability in the magnitude of the effect. And so some were stronger than others. And so I just want to point out too, um, uh, received support, this top one, had the weakest effect, whereas complex measures of social integration that basically encompassed multiple aspects of relationships was the strongest. And so my point in showing you this is not to overwhelm you with data, but rather to highlight the fact that no one aspect of people's social lives is sufficient to understand individual differences in the complexity of our social life, much less how various aspects combine within individuals to influence physical health. And so based on this, my colleagues and I, based on this cumulative epidemiological data, my colleagues and I proposed this concept of or the term social connection, and because the evidence supports a wide range of measurement types by which social connections influence health risk. And so this social connection can be thought of as an umbrella term that gets at the extent to which individuals are socially connected to others through structural, functional, and quality. And that all of these different measurement types tend to fall under these three key categories. And so it's the connection to others via the existence of relationships and their roles, a sense of connection that results from actual or perceived support or inclusion, and a sense of connection to others based on the positive and negative qualities. In other words, the structure of our relationships, or in other words, the presence or absence of others in our lives matters. What they do or the degree to which you perceive you can count on them matters. And the quality, those positive or negative aspects matter. And each of these are significant predictors of risk or protection, depending on the direction. But importantly, are not highly correlated with each other, suggesting that each may be contributing to risk and protection in unique ways. And it's important to note that there are now multiple meta-analyses that include hundreds of studies and millions of participants that document this effect on some component of social connection or disconnection and mortality. And while there's variability in the strength of the effect across measurement type, each converge on a similar conclusion. Being more socially connected is protective, and lacking social connection carries risk. So let's get back to, again, what does this mean? How do we contextualize this? What does that 50% mean, or that 29%, right? That I mentioned earlier. So we know that lifestyle and environment are significant predictors of health and longevity. There's strong evidence of this, and this chart represents just a few. This includes smoking, obesity, air pollution, and their relative strength of influence on the risk for premature mortality. And so you can see some are stronger than others. And so we decided to benchmark the effect sizes found in these other meta-analyses relative to these other risk factors. And as we can see, the social factors depicted here in the orange bars are comparable and in many cases exceed the risk associated with some of these other factors. Factors, of course, that we take quite seriously for health. Now, of course, some variables were inversed since some are protective and others are associated with risk, so that each bar represents the strength of the effect on survival. And although they vary in their magnitude, even the least robust of these, loneliness, still was found to exceed the risk associated with physical inactivity, obesity, and air pollution, suggesting our social lives may be just as important for our health as these other factors that are prioritized in public health. So to summarize, overall, the cumulative evidence suggests that the magnitude of the effect of being socially connected or disconnected is robust and comparable to other risk factors. This was consistent across cause of death, although the majority of these were disease-related causes of death. We also found that both objective and subjective indicators of social deficits, so both loneliness and isolation, significantly predict risk for premature mortality. So, in other words, both isolation and loneliness are important to understanding an individual's risk, and one shouldn't necessarily be prioritized over the other. Also, this data controlled for a variety of potential confounders, including age, initial health status, pointing to independent risk and ruling out reverse causality. And then finally, the data points to a continuum of risk rather than a threshold. And other data also shows a dose response effect, meaning that for every increase in social connection, there was a decrease in risk. However, of course, even though we have all of these meta-analyses, there are gaps in our evidence. Because of course, meta-analyses can only summarize what evidence exists. And so there are fewer studies that examine individuals at younger ages and across the developmental course. There are fewer from developing countries. There are fewer that examine cultural, ethnic, and economic differences. There are fewer that measure relationship quality. And because there's some evidence suggesting that negativity in relationships are associated with risk, failure to account for this in studies may have inadvertently averaged the positive and negative effects, suggesting that the estimates presented here may actually be conservative estimates. And if quality isn't assessed, we also may potentially miss risk. But also fewer studies assess multiple components, and even fewer examine their synergistic effects. So what are some of the effects that go beyond mortality? Because of course, mortality is just one outcome. Certainly it's one that I focused on because it's so objective. You're either dead or you're not. There's not a lot of ambiguity there. But there is growing evidence of additional effects beyond risk for premature mortality. And these are consistent with this. So there's evidence that social isolation and loneliness also influence a variety of health outcomes. These include physical health, so increased risk for heart attack and stroke and type 2 diabetes. It's been associated with mental and behavioral health, including increased risk for depression and anxiety, suicidality and addiction, as well as cognitive health, mild cognitive impairment, dementia, and Alzheimer's disease. There's also evidence that social isolation and loneliness even influences economic outcomes. For instance, a recent AARP study found that social isolation among older adults is associated with 6.7 billion in annual Medicare spending. Now, of course, the economic burden of isolation is likely much larger, given that isolation and loneliness linked to the workplace has been linked to greater absenteeism, lower productivity, and lower quality of work. Importantly, we also have growing evidence of the body of evidence that documents how these effects occur. These aren't just necessarily interesting correlations, but evidence of the pathways by which these effects can occur. And these include psychological, biological, and behavioral. So for instance, the distressing feelings of being isolated or lonely can heighten stress, triggering increases in heart rate, blood pressure, stress hormones, and inflammatory factors, which, if this is sustained over time, can lead to wear and tear on the body. For example, work by Steve Cole has illustrated how loneliness is linked to a state of threat, signaling a sympathetic response, including the release of norepinephrine in bone marrow, priming an inflammatory response. And chronic levels of inflammation have been linked to mental, cognitive, and physical health outcomes. And these chronic illnesses, in turn, influence one's risk for earlier death. So, chronic inflammation may be a common pathway that might help explain some of the diverse outcomes associated with social connection, given that chronic inflammation also has been linked to social factors, physical health outcomes, including cardiovascular disease, cancer, diabetes, as well as cognitive health outcomes, including Alzheimer's disease, as well as mental health outcomes, including depression. The immediate effects of social isolation may also extend beyond mental health concerns and influence on our biology, but also to influence our behavior. So for example, there's some evidence to suggest that may be related to problematic health behaviors, including substance use, poor sleep, and emotional or overeating. Now, despite a very complicated literature, the National Academy of Science Consensus Committee found substantial evidence that social isolation and loneliness are associated with greater incidence of major psychological, cognitive, and physical morbidities, and lower perceived well-being and quality of life, with some of the most compelling evidence coming from the association of social isolation with significantly increased risk for premature mortality from all causes. And this is a quote from that report that you can read more about. Now, while there's compelling evidence of an association with health, is it causal? And that's a big question and a complicated one. Because establishing causality can be quite challenging, particularly for factors that are not easily manipulated in experimental studies. And so few epidemiological studies are experimental. And so there is certainly cause for concern here. Nonetheless, other public health issues, most notably smoking, faced similar challenges. And the Bradford Hill criteria was used to address these challenges. So what this criteria includes is 9 criteria or guidelines that lay particular emphasis on the time course or temporality of the relationship, the strength of the relationship, just how strong or is the magnitude of that. The presence of plausible dose response relationship, and the consistency of findings across diverse studies, as well as coherence with other disciplinary findings and biomedical theory. Now, other researchers, Hoek and colleagues, evaluated this evidence, this Bradford-Hill criteria for causality. They evaluated the evidence for social connection against these same criteria. And so I note some of the supporting evidence here that supports each of these criteria. So using these guidelines, they concluded that the evidence supports the causal link between strong social connections and better health and longer life. Now, nonetheless, of course, I do want to acknowledge that of course, additional data is needed to strengthen this even more. Now, we may have strong evidence of the long-term effects on chronic health and earlier mortality, but is there evidence related to susceptibility to viruses? And so I'm sure some of you may be curious. And a recent review was published summarizing 35 years of studies, identifying factors associated with susceptibility to cold and flu viruses. And in the series of studies, results showed that participants experiencing interpersonal stressors, including loneliness, had a greater chance of developing an upper respiratory illness when exposed to these viruses. Further, with those that actually had greater support, were more likely to mount an effective immune response to a vaccine. So now, of course, caution should be taken given these studies involved common cold and flu viruses. But nonetheless, this data suggests that there may be really important implications for how this might be applied to our current situation. Now, what are some additional health implications from this pandemic? And of course, we do not know the full health ramifications of the pandemic yet, nor are we likely to know these for some time. Nonetheless, there may be additional health implications as a result of social isolation and loneliness. And I want to point to a couple recent studies. Recent evaluation of a nationwide database of electronic health records, including 61 million adults, found that patients with a recent diagnosis of a mental health disorder had significantly increased risk for COVID-19 infection, hospitalization, and mortality. And this is relevant because of the strong evidence of the bidirectional associations between social isolation and loneliness and mental health. The short-term restrictions associated with the pandemic may also trigger short-term biological responses among those with pre-existing health conditions. And these changes in physiology and behavior could potentially exacerbate the condition and precipitate the onset of acute events or hasten disease progression. So there are also questions about and continue to remain about who may be most at risk during the pandemic and in the aftermath. So one comforting sentiment throughout this pandemic has been the idea that we're all in the same boat. A sense of solidarity that we're in this together, and the comfort that you aren't alone in this struggle. And I appreciate this analogy on the one hand, because it helps to reduce stigma around social isolation and loneliness, and helps perhaps individuals to feel more comforted and open about talking about this. However, I think it's really important to acknowledge that this analogy is flawed. Perhaps a better analogy is that we're all facing the same storm. Many of us, um, the same storm, but clearly in different boats. Some of us might be in a yacht, others in rowboats, some may be going solo in a kayak. In other words, we are not all equally equipped to weather the storm. And the pandemic has highlighted a number of inequalities. Um, Many of which existed prior to the pandemic, but have become magnified during the crisis. And this provides an opportunity for us to better understand and address these inequalities. Data from both the UK and the US confirm that the risk factors that existed prior to the pandemic continue to exist during the pandemic. Those, for instance, low income or education, unemployment, living alone, and poor mental or physical health all consistently predict higher risk. So it's clear that continued prioritization of social isolation and loneliness is needed. But what can we do to mitigate the risk? Both short-term and long-term public health concerns will emerge if steps are not taken to mitigate these effects. Now, going back to that analogy of loneliness as a biological cue, similar to thirst, during this pandemic, the challenge to reduce risk has been exponentially compounded. So, again, if loneliness is similar to thirst, it's as if we can't or haven't been able to access what we crave most. It's as if we've all been incredibly thirsty, but being told that the water is not safe to drink. And so we've faced this challenge of how to satisfy this biological need without close proximity to others. Now, the challenge is very real. There's currently no pill to solve this problem. And although pharmaceutical approaches are being explored and researched, no one approach is likely to be the right solution for all, given the variability in underlying causes. So tailored approaches are going to both be needed and are recommended by the National Academy of Science Expert Consensus Committee. But one of the most important gaps in our evidence is data on effective interventions. Currently, the data is mixed, meaning that some interventions are more effective and successful than others. There's no gold standard approach to recommend. And to some extent, there's a disconnect between the interventions and the evidence that was established, that established its importance. So for example, the majority of the epidemiological data that shows such strong health effects is based on existing close connections and in-person connections. And yet many of our interventions are implementing hired personnel or volunteers that are strangers. And so we need to acknowledge that while these may be successful in some cases, that there may be some limitations as well. This also points to another important gap. The evidence that I presented earlier is primarily based on in-person contact. Many of the longitudinal studies began prior to the widespread use of smartphones, social media, and other digital means of social connection. And so we currently have less evidence of the equivalencies of connecting via digital means. And yet, in response to the pandemic, tech solutions are being relied upon more heavily than ever. And so, of course, this points to the need for remote means of connection, and effective digital means of connection are needed. I do want to point out one study, just highlight one study I did in collaboration with my colleagues at UC San Francisco, where we examined the experiences of older adults in the San Francisco area during the shelter in place orders. And we collected these via telephone surveys. Um, Now I want to, acknowledge this is a small sample among vulnerable community dwelling adults. But what we found was that most older adults use telephones as their primary means of connecting. 76% had little or no video contact, and 26% reported having no internet. And this wasn't a rural area. This was San Francisco. So what this data suggests is that many older adults may not be using digital tools. So it's important when considering our solutions, digital or otherwise, that they're actually reaching those who may be most in need. Um, Similarly, there was some data from the National Poll on Healthy Aging that found that the majority of older adults did not use video chat, and the use of video chat was unrelated to loneliness. The survey also found that 59% of adults connected to friends via social media. However, those that did use social media were actually more likely to report feeling isolated. So, my point of bringing these studies up is to suggest that we can't assume that all social contact is equally effective in reducing isolation and loneliness. Um, we also must think beyond just access to digital tools, which is, of course, important. But our data also suggests that there is variability, at least among older adults. And so we shouldn't assume that all older adults do or do not have access, feel comfortable, or desire to use some of these tools. And so some of these factors need to be considered. So I wish I could give you a silver bullet and tell you, okay, here's what you should do to solve this issue. But instead, what I can offer you is a framework. Solutions can benefit from a systems approach. A systems approach recognizes that individuals are embedded within social structures such as families, neighborhoods, communities, society, and culture. Each of these levels contribute to health in different ways and may be interrelated. So it's important for us to consider each level in terms of both causal factors as well as potential interventions to modify risk and protection. And of course, this deserves much more detailed discussion, but I do want to just simply highlight a few approaches that are focused on the individual level, community level, and then potential societal level. So let's start with individual level. Most clinical interventions that we see in the literature are aimed at the individual level. And my colleagues recently conducted another meta-analysis focused on the effects of social interventions on medical patient survival. This paper is in press and will likely be out in, I think, just a couple weeks. This included 106 randomized clinical trials and over 40,000 participants. And what we found was a 20% increase in survival among those receiving social interventions compared to control groups, and a 20% increase in survival time. So what that suggests is that psychosocial interventions aimed at strengthening coping and reducing distress significantly improve survival. But I do want to note that there was considerable variability among these interventions, with some that were more effective than others. And so this also suggests significant room for improvement. Now, the CDC uses a social ecological model approach to address other risk factors. And we know from other behavioral and lifestyle risk factors that individual-based interventions haven't had as much success as preventative efforts, as well as community and societal level. So what opportunities are we currently missing by primarily focusing on an individual level? We also need to recognize that if we draw upon that evidence I mentioned earlier that showed a dose response effect, it suggests that every one of us is somewhere on this continuum of social connection from low to high. But most individual level interventions are only targeting those on the extreme end of the spectrum. In other words, even if successful, these interventions only reach a small portion of the population. So I want to highlight a community level intervention. So at community level, there are several interventions. Unfortunately, many of them are untested, as they are often grassroots organizations that have limited budgets. And so recently I was asked to get involved with one aimed at neighborhoods. And so to do this, my colleagues and I worked with the app Nextdoor to conduct an international randomized controlled trial. And what we found was that participants who are randomly assigned to perform small acts of kindness in their neighborhood showed small but significant reductions in loneliness, as well as reductions in conflict with neighbors. Further, it was found that knowing at least 6 neighbors led to lower loneliness and was associated with lower depression and financial concerns due to COVID. We also need to find societal level approaches. And so by focusing on the protective effects of social connection as part of a healthy lifestyle via population-based solutions, instead of just affecting the extreme ends of the spectrum, we may potentially begin to be able to shift population level risks. And of course, the pandemic highlights the need for action at the population level, right? And the recent National Academy of Science report lays out several recommendations based on available evidence. So this report had 5 goals, each of which addressed an aspect of enhancing the role of healthcare system in addressing health impacts of social isolation and loneliness. These goals are to develop a more robust evidence base, translate current research into healthcare practices, improve awareness, strengthen ongoing education and training, and to strengthen ties between the healthcare system and community-based networks and resources. And the report provides recommendations related to each of these goals based on currently available evidence. So I want to just highlight one result from this. So in direct response to this report, we are currently working on a national clearinghouse housed under the Administration for Community Living under Health and Human Services. The goal is to create a centralized national resource of evidence-based solutions and best practices. And our hope is that this will become a tool for community-based organizations as well as policymakers and researchers to develop and support person-centered interventions for their populations, keeping in mind a social or socio-ecological framework to increase the greatest impact. The goal is to organize efforts across sectors and organizations to reach up to 10 million socially isolated people and connect them with appropriate informed solutions to decrease isolation and loneliness. I want to point to another potential solution. In 2014, the Institute of Medicine evaluated factors for inclusion in the electronic health record. It identified social connection as one of the 10 factors most predictive of health outcomes, and that should be included in the electronic health record. And the 2020 National Academy of Science report concurred with this recommendation. And the Gravity Project is currently working on creating a standardized approach to do this. One of the things I do need to acknowledge, though, is that there may be some barriers. So, for instance, if we screen for risks, physicians and healthcare practitioners may not know what to do with that information. And so, based on the National Academy of Science consensus report and recommendations, colleagues and I have proposed a framework of a listening ear. And EAR is really an acronym for educate, assess, and respond. In other words, to educate both the healthcare professionals as well as patients on the health risks associated with this. And that can be included in preventative efforts. Also to assess the risk level of patients, not only in primary, but in secondary and tertiary level care, and to be able to determine changes long-term. And to respond, to refer patients to local sources that are tailored to their needs. And that can be done by identifying some of those sources through this national clearinghouse. And then, of course, part of that response is to reassess, to determine if those sources are meeting individuals' needs or what may be better suited. We also need to think beyond community and clinical level approaches to think about potential policy and societal level. And the pandemic has provided an opportunity to carefully evaluate the public health consequences and strategies implemented at a population level. So over the past year, there have been a number of adjustments that have been made simply to stay afloat during this crisis. Some of these have been short-term changes that are necessary to get through the crisis without too much harm. Other changes may be more permanent, with the assumption that these changes will help fortify us through the next crisis. Understandably, many are concerned about the aftermath of this crisis. However, most of these concerns are focused on the economic recovery, and there may be a need for a social recovery. Social contact is a part of every aspect of life, and this has become abundantly clear during the pandemic because nearly every aspect of our lives has had to be altered. We have seen changes in the way we live, work, play, and the way we age, all social determinants of health. To what extent are these going to be sustained long-term? We also know that the built environment can have substantial influences on public health. And to what extent will the pandemic change the way in which public spaces are redesigned to create greater distance that could have longer term implications well beyond the pandemic? And we also need to consider public health policy. So drawing on the World Health Organization's framework of health in all policy, we can consider the social ramifications across sectors of health, transportation, housing, employment, nutrition, water and sanitation. This global experience may yet provide an important opportunity for us to redraft policy so as to alleviate further social isolation. The National Academy of Science report recommends cross-sector collaborations to address the health implications of social isolation and loneliness. and to foster greater social connection. By working together to solve this issue, we can better identify effective and novel solutions and approaches. We need to work together to ensure that we're reaching those who are most vulnerable and can tailor approaches to unique populations and contexts. We need to apply the most rigorous science so that these approaches will be effective and taken seriously by funders, policymakers, and users. It is clear that no one sector can solve this issue alone, but together we can begin to make the changes that are so clearly needed. And when we all work together, all boats rise. Thank you.
Well, thank you so much, Dr. Holt-Lunstad, for that provocative and informative lecture. Lots of great comments are in the chat, and there's some good questions that have been advanced as well. And so I'm just going to launch in and begin asking some questions. Is there a difference in the need for connection related to personality? If someone likes to be alone, is it still harmful to be alone?
So that's a really good and complex question, and one that I get often, right? And so, it's interesting because, of course, this, I think, also got highlighted during the pandemic. I'm sure we all saw the memes. Introverts have been, preparing for this moment their whole lives, and that we all need to reach out to our extroverted friends, right? And so there's this assumption that perhaps personality factors such as introversion and extroversion, that it may impact people differently. And of course, this makes sense because if you think back to the definition of loneliness, it is that discrepancy between one's desired level of connection and one's actual level of connection. And so what that expectation or desired level of connection may differ depending on, personality. It could depend on gender, culture, a number of factors can potentially influence that expectation. And so regardless of that, what the data seems to suggest is that if you are lonely, there are these negative health effects. The more complex question, though, is whether if you're isolated but not lonely, does that still carry risk? And according to the meta-analytic data, social isolation does indeed independently carry risk. However, fewer studies look at it within the same sample. So we have this whole set of data where they look at individuals who are isolated and calculate the risk. And there are these studies that measure loneliness and calculate the risk, but few studies look at whether people are, whether there's greater risk associated with being both isolated and lonely, presumably compared to being either lonely or isolated. And so there are a handful of studies that have done this. And interestingly, what they suggest is that social isolation may be more impactful. So when you control for loneliness, isolation still remains significant. And in some cases, when you control for isolation, the effect for loneliness goes away. I want to acknowledge that there are very few studies that have done that. So I don't want to, make any kind of definitive kinds of conclusions because we have less evidence there. But what it does suggest is that there may be something important about simply being isolated, even if you don't feel lonely, that may carry risk. And so that's something that we definitely need to explore more in the evidence for sure.
Thank you for that. Kind of a related question. Have you found a connection between loneliness and chronic illness?
Yes, yes. So there has been evidence that links this to a variety of chronic illnesses. The strength of the evidence is, and when I say strength, meaning there are more studies looking at cardiovascular kinds of outcomes. And so this has been associated with increased risk for cardiovascular uh, risk and stroke. There is some evidence, although fewer studies, linking loneliness to diabetes and cancer and other kinds of morbidity kinds of outcomes. So we have more evidence when it comes to cardiovascular outcomes, but we do have evidence with other kinds of health outcomes. Yeah.
Mhm. And would you want to speculate at all on why there is that connection between, loneliness, social isolation, and chronic illness?
Yeah, so I think it gets, to those some of those pathways. And so I touched on inflammation as a possible one, which um makes sense in the sense of it really ties together a lot of the complex literature in the sense of that distressing feeling that we feel is in the central nervous system has been associated with threat kinds of responses and activation of systems that trigger heightened alert throughout the body, and that 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 when these are activated long term can put us at greater risk. But we also need to acknowledge that there are additional pathways. There are the behavioral pathways, other biological pathways, and some that are that we're still trying to better understand. So, for instance, there's some research that is starting to explore the role of microbiome, the role of oxytocin. Um, so there are these various biological pathways, but then there are also the behavioral pathways. And so, for instance, we have evidence that those who are more socially connected and supportive have just engage in healthier lifestyles, and that those who are isolated and lonely tend to have more problematic behaviors, engage in riskier kinds of behaviors. Um, Including poorer diet, greater substance use, greater sleep disturbance. So all of these sorts of things, of course, can put people at increased risk.
Mhm. So the next question is a pandemic related question, Julianne. Do you think that there exists a significant difference in the experiences of social isolation and loneliness between essential workers who had no choice but to continue to work in person and those who were able to work from home? On one hand, essential workers may have been able to see and interact with people at work in person, but those who stayed home every day, despite not leaving the house, got to see messages of we're all in this together while staying home on social media from celebrities and in marketing campaigns. What are your thoughts about that?
Okay, so first off, as you mentioned this, there are a couple studies that have looked at specifically at essential workers, and sadly, I cannot recall whether they can compare them to non-essential, those who are staying home. Um, and so, unfortunately, I can't recall the effects of this, so I can't, uh, tell you what those exact findings were. But we also know that there's only just been a few studies, and so I imagine that that there are going to be many more studies coming out that will look at this. And I first off want to certainly acknowledge that. when we look at differences, we're often looking at group differences. And so we're averaging, right? And, but we all know that, that there's not a uniformity to experience even within those groups, right? Even among those who stayed at home, so many differences, depending on your living situation, whether you live in a house or an apartment, live alone with or with others, whether you had small children, how economically stable. There are so many factors even within those groups, that we need to acknowledge. And there would be likely be variability with among the essential workers as well. And so my hope is that when we emerge from this, that we've learned from it, and that we can acknowledge that there is, in essence, a shared experience, but also a an acknowledgement of unique circumstances and unique challenges and struggles too. So that I hope that we, emerge with more empathy, as a result of this. I know it wasn't a great question, or sorry, a great answer. Sorry, it was a great question. My response, I unfortunately feel like it's too soon to tell.
Well, I think, Julianne, though, your insights, I think are helpful. My own sense is people are going to be studying this for decades. And as you say, everybody's experience has been pretty unique. So even people who went to work in person, and I'm thinking of healthcare providers that worked on the front lines, being, all the PPE they had to be wearing, oftentimes there was very little opportunity to really interact either with patients or with even coworkers. So I think for many healthcare workers that worked on the front line, it was a very isolating and lonely experience. So yeah, I think that for sure we don't know yet the full implications
Yeah.
of all that.
Yeah.
So on the topic of healthcare providers, though, there's another question that I wanted to ask, and then there's more that have also, been sent in. I thought you made such an excellent point that the role of healthcare providers are really critical in terms of, when they interact with patients, and really even thinking of screening for questions that would point out social isolation and loneliness. Beyond asking a question of, do you live alone? Are there other good screening questions that you want to be pointing healthcare providers to?
Yeah, no. So this is something that I'm working with a Gravity project right now to try and really address this. And this is challenging because, as I pointed out, there are so many different well-validated instruments, but they don't necessarily capture the same thing. And so, we know that just because you live alone doesn't mean that you're isolated or lonely. And so we need to ask additional kinds of questions. But we also know that there are incredible demands upon physicians and healthcare providers. And so time and practicality is a concern too. So we need to make sure that it's feasible, that it's not too long.
Yeah.
And so that's a challenge as well. But I can point to some of the well-validated instruments that are widely used to assess risk, at least in research. And that is, for loneliness, the UCLA loneliness scale is widely used. And although the full version is 20 items, there are short versions. There's a 4-item and a 3-item. There's also the social network index, which looks at social integration. And then there's also the promise tool. And those I'm just gonna, there's many more than that. I don't want to, come off as though those are the only three, but those are just, a few that I can point to right now, or highlight. But our hope is that through this, that we will be able to find a way to adequately capture risk in a way that can be feasibly implemented within clinical settings.
Yeah. Yeah, I think it's going to be so critical to be able to go beyond the research instruments that we need so much in research studies. But I'm thinking of other projects that have looked, for example, at depression and identified screening questions to ask for, depression or risk for, being harmed, in your home. I think for this whole topic of social isolation and loneliness, given the time factor that you have, so well pointed out, it's going to be important to identify, are there, 2 or 3 just screening questions that we can ask that might, lead us to, to more important questions.
Right.
Somebody put in the chat, I just want, go ahead.
No, I was going to say, I mean, it could be that we, find a few key items that will potentially flag someone who might be at risk that we can then follow up with more detailed questions.
Yeah, absolutely. Somebody put a comment in the chat that I just want to acknowledge, that healthcare workers working directly with COVID patients also felt very isolated from social media. Seeing social media and having people who we thought we knew and had shared values with act like COVID was no big deal and not follow public health guidelines made connecting with many individuals so much worse and isolating. And I have to just acknowledge your comment, Sarah, and say, I have heard that from many of my friends and colleagues who have worked on the front line, that was a common and very, very difficult experience. Another question, and lots of comments saying things like, fantastic talk, Dr. Holt-Lunstad. I've been a fan of your work for some time. This question is, what is known about the importance, if any, of the size of a person's social network? In other words, do people with more friends do better? Or is it really just quality that matters? I'm also wondering about personality trait correlations, if there's anything there.
Yeah, so yes, there is some evidence to suggest that size matters, but quality matters. So the one study that I shouldn't say study because it was actually combining data from 4 nationally representative samples. I touched on it, but I didn't have a chance to go into detail. So these were 4 nationally representative samples, and it included individuals across the life spectrum from adolescence to older age. And this is the data that found the dose response effect. And what that data included was structure, function, and quality of measures. They included all 3 of those components. And so what that suggests is that we need people in our lives, but we also need high quality relationships in our lives. And so there is that dose response effect, but of course it was constrained within the parameters of how these studies measured that size, right? So we don't necessarily know that having, say, I can't remember off the top of my head, I apologize for that upper limit, but once it gets beyond a certain point, are there diminishing returns? We don't know that upper limit. And so we don't necessarily know that someone with 50 versus 150, there's any difference, but there does seem to be a difference between, say, someone who has fewer than 6 and between 6 and 9, or 9 to 13. And so we do know that there is a difference at those lower levels. What we have less evidence of is far beyond that. But that does also take into account quality. And so meaningful relationships are important. And as I mentioned, relationships that are associated with negativity, conflict, strain, these have been associated with risk. And so I think that often gets overlooked. I mean, I think intuitively we all know, like, of course, not all relationships are positive. And so really it's, the protective effects are of high quality, positive relationships, and negative and poor quality relationships can actually put someone at increased risk. And so we shouldn't ignore that, because I think a lot of times in efforts and well-meaning efforts to try and decrease someone's risk, it might just be, well, let's increase the size of your network, or let's increase this, the frequency of your social contacts. But if we don't pay attention to the quality of those and how meaningful those are, and the functions that they provide, they may not have the benefit. And so, that question, I think, is really important to acknowledge that that quality and the meaningfulness of those relationships is indeed very important.
So there's a couple of questions about pets.
Oh.
One person writes, I'd be curious to know how much of an impact is having pets to overall loneliness, such as did individuals with pets fare better during the pandemic than those who did not connect, to health and loneliness. And then somebody else asked, do pets count as social contacts and reduce social isolation and health risk? And as you're thinking about those questions, I will just throw in, I sure saw a lot of people getting pets during the pandemic. I don't know if you observed that as well.
Oh, no, I think that there were, media reports on, puppy shortages and, many people getting pets during the pandemic. I just want to, provide the disclaimer that my research focuses on humans and the benefits associated with humans. And so I'm less familiar with the research on pets. But I get this question all the time that I keep thinking, oh, when I have free time, I should really, do a deep dive on this, because I feel like I should know the evidence better, given I get the question so often. I can say that there are several studies that have looked at this. But it's what's not clear is how strong that evidence is. So there's a lot of evidence that suggests that it is associated with positive outcomes. The potential limitations are that some studies don't necessarily compare that to, say, pets versus humans. It may just be pets versus no pets, or in many cases, they're not even comparing it to someone who doesn't have pets. It's looking at someone's, say, their loneliness levels prior to getting a pet and then after getting a pet. And so, we may not know what that difference might be compared to those that may not. And there's some question about what the mechanisms are. And so there are many plausible reasons that pets could be beneficial. So there is the companionship, the comfort, right? But pets, and where there are some significant studies, including cardiovascular outcomes, have been with dogs. And that's because dog owners tend to walk dogs. And so this means greater physical activity for the dog owner, as well as interacting more outside and potentially with others. It can be a conversation starter if you're going to a dog park or, with others in your neighborhood. And so there may be multiple ways in which that can occur, but there are some studies that show cardiovascular benefits associated with, at least with dog ownership. And there's some evidence starting to examine even robotic pets, but that's much more limited, and I think we need more evidence still.
Yeah. Somebody points out the good point that it's not just healthcare workers that should be checking in on others. We can all take a role in this. We should be asking our elders or our friends to gauge where they're at. One of the things I really appreciated in your talk today is your focus on community-based interventions. And a few years ago, I read about such an interesting community intervention in the Netherlands. In a grocery store, they created a chat checkout, where if you went to that particular checkout lane, it was particularly for elders, but anybody, expect that it was going to be slower because whoever was checking you out was going to have a chat with you and check in. And I thought, what an interesting example of a social intervention that a grocery store initiated. They also established a coffee corner for that same reason. Well, many more questions that we were not able to get to all of them, but I just want to thank you so much, Dr. Holt, for your presentation today. And there's lots of, as I said, positive comments in the chat, and people put the applause sign. It's so weird with this Zoom. We can't, applaud you like the way we would like to. I want to also acknowledge and thank all of our staff at the Bakken Center who helped make today's webinar possible. Today's free lecture is made possible through the generosity of our university and community sponsors. We appreciate their commitment to health and well-being of people in Minnesota and all around the world. We hope that you'll join us for our next Wellbeing lecture on October 20th. Dr. Andrew Williams will give a presentation titled Afro Soul: Dreams of Freedom, Racial Reconciliation, and Healing Justice. So hope to see you then. Thanks for being with us today.
Thank you,
everyone. Take care all.